up. Some people, I got them up and out of bed to join us. So you might notice that the one corner is a little bit not filled in with a person yet, because Dr. Bacchus is trying to join us. So this morning, I'm so happy to have this wonderful.
Being recorded?
Oh, yeah. Dr. Mansoor Mirza is joining us, who is one of the lead Ruby investigators, with Dr. Matt Powell, who's another Ruby investigator. Dr. Flora Bacchus has just abandoned us in terms of the video aspect, and she is doing fantastic work with being the PI of several endometrial cancer studies. I actually probably should have told you while I was recording you before I started. But this morning I woke up to an email that Matt had sent many of our key colleagues around the world regarding his insights or thoughts about endometrial cancer. And Dr. Mirza quickly, I'll go with first name. Mansoor quickly responded with his thoughts, as did Dr. Dave Much. So it's like, let's get everybody really quickly on a Zoom meeting and talk about this. So as you probably recall, we had some fabulous presentations at ESMO, adding on to the great presentations from the 2023 SGO meeting from GY018 and the Ruby trial. I honestly would have woken up Dr. Ramez Eskander, but he's all the way in California, and I just felt too guilty about calling him at like 6:30.
Well, you did send him an email at 4:30 in the morning, by the way. So,
Well, here we go. And Dr. Flora Bacchus, I'm so sorry. I did not tell you we were recording. So you just got Zoom bombed by SGO. So here we go. So please tell me, I want to hear from all of you, what were your thoughts coming out of the ESMO meeting with the updated presentations from GY018, Ruby trial, as well as the presentations from Attend and DuoE. And let me tell you, you only just get one snippet, one high level point. You have 30 seconds to make it, and then we're going to go to the next question. So go for it.
Mansoor.
Yes, perfect.
I would say that I feel DMMR is a no-brainer. This is just job done. Of course, we have to find out who are the patients who do not respond, but job done. But when it comes to the PMMR is a jungle. We have to do the molecular classification. We have to nail down who may be responding. Even in the DuoE study, where it was not powered to look at B versus C, but still look at the P53 mute and P53 wild type. I bet that we will see that the efficacy is coming from P53 mute population. And we don't have yet a solid background how to do the HRR that we have to work upon.
Yeah, absolutely. I'm going to go to Flora next.
Was the
We hear you now.
biggest surprise also was the PMMR population in Ruby and as well as the lack of total benefit in the NSMP group. And really we struggle now with the DuoE, like where do we go from here? PARP or no PARP, and where do we put it, and how are we going to test these patients for HRR, or what should we be doing?
Yeah, these are all really brilliant observations. I'm going to turn to Matt next.
Well, thanks, Angeles. And I feel your enthusiasm. I certainly have it as well. There were so many great things presented and really changing the way we take care of patients with endometrial cancer. I know I just used up 10 of my seconds right there. But to echo what Mansoor said, I think, one of the keys is I put everything together. It looks to me like PD-1 or anti-PD-1 approaches are probably better than anti-PD-L1 approaches, kind of across both our single drug experience and even when you combine it with chemotherapy. As Mansoor is exactly right. We got to get these subsets right. We have to understand what kind of mismatch repair it is. Is it somatic or germline? Is it promoter methylation? And was it previously exposed to chemotherapy or radiation? I think that impacts these outcomes. And I know we have some exciting things that your group's presenting coming up as well that will shed light on some of those features about radiation and such. So I don't think I'm ready to give my patients PARP inhibitors with endometrial cancer yet, but just as Mansoor said, there's clearly a group of patients that benefit. Now, the OS data from the maintenance PARP study really concerned me. It actually looks like we could be hurting some patients when it comes to OS with use of PARP and endometrial cancer. So, I mean, that story needs more time, needs to develop. I think we're on the right path for using the current tools we have to really help the lives of our patients.
Yeah, I think you're talking about, are we talking about the UTOLA study, which is PARP inhibitor only? Yeah, I don't know if we'll have time to get to that, but I'm going to try to share my screen. I will say I'm a self-professed IT idiot. So let me see if I can get this right. So my computer is so messy right now because I have all these endometrial cancer slideshows up. So let me see if I can do this, play from
I
current.
love you start with the DMMR.
Yes, you got it. That's exactly where we're starting. So I think, just like Mansoor said, we now have all these different studies, right? Look across the board there. GY018, Ruby, Attend, DuoE, all showing this profound benefit. And I wanted to highlight something. I was looking at this, you look at the 24-month time point here, and you see this, for some of these studies, it starts even at 12 months, but you see this plateau, right? 12 and 24 months plateau where nothing really changes. What are your thoughts about, do we need to be treating with these drugs for that long in the maintenance setting?
Well, that's the next question we have to answer. That would be another new trials doing good to have shorter therapy, at least in DMMR. I don't think that will go in the PMMR population in case we continue to give PARP inhibitors. But we also need to look other way around. Who are these patients who are progressing until 12 months? And that is the major area of concern for me, to find out these patients so we can do something better for them.
I wanted to also call attention, Matt, you made a comment about one class being better than the other. I am going to challenge you a little bit on that because there were some differences in inclusion criteria in these studies. And I think it'd be very difficult to say that at this point.
Yeah, I'm talking just about trends. These are all hypothesis generating observations. And I don't want anybody to think that, I know the answer to these things, but I think across these studies, and I don't know if you want to go to the eligibility slide that I developed with I'm not sure what number slide that is, but I mean, we could talk about the difference in eligibility, whether they had 12 months chemo-free interval, whether they had radiation. I mean, all these factors are going to be critical to try to cross-trial compare without cross-trial comparing. And again, that's a hazard we have, but as we try to think of moving the bar forward, we really have to be careful and get all the right molecular tools at our fingertips to compare it. You want to flip to that slide?
You know what? This is such a mess. I'm going to go to the next one first. If I can go to the last one, I will, but I'm worried I will make everybody have a seizure.
Okay.
Because the slides are so packed.
One other thing to call out here. Can you guys hear me?
Yeah,
Yes.
absolutely.
To what Dr. Mansoor said about, Dr. Mirza said in the first 12 months, what can we do in this population? Can we start thinking about maybe some of these patients will need to do dual? The question is, for those patients where we see those curves still overlapping, and we've talked about this before, during chemotherapy, is chemotherapy absolutely needed in this population at least? Even though we see response rates still improved response rate, doubling of response rates with chemotherapy with IO versus chemotherapy alone, but do they need in it? And we have exciting trials coming out.
We will partially answer that question from the EN13 and EN15 trials, which are chemotherapy against either dostarlimab or pembrolizumab. But unfortunately, those trials now have an inferior standard of care arm, which is chemotherapy alone. So I would have wished that we had some changes in those two trials to add immune checkpoint inhibitor in the standard of care arm, but we don't have it. But we will get some evidence from that.
Yeah, those have some non-measurable patients, and we have some fear that non-measurables may not get this benefit, especially with this enthusiasm around neoadjuvant treatment approaches where you have tumor and you're educating the immune system when there's known tumor there. That may be a critical portion of what we're dealing with, because the trials that we're showing you on this slide all mostly had measurable tumor to where the immune system's interacting. And I think that there could be some holes in our strategy. So I think doing more trials, understanding the implications of the trials are so critical for planning our next study.
Yeah, but Matt, we have to be careful. The number of patients with non-measurable disease were small in these trials, and
Yes.
the event rate is very slow. So I believe the biggest trial we have there is B21, chemotherapy plus minus pembro, 1,000 patients, and we have to wait for the mature results of that trial before we make any statement.
I completely agree with you, 100%.
This is one of those situations where I think you are all correct. And thanks for bringing that observation forward, Flor. I think the C93, the Dominica study, and the LEAP 01 study will add to the body of knowledge as we go forward. But as Mansoor correctly said, the control arm is no longer the correct control arm. And that's the speed and acceleration of which research is being conducted at this point, where we basically have to rewrite a manuscript every 3 months at this point in time, or a chapter. The way that we used to do, our dissemination of education is completely changed in this new era. I'm going to go to this next slide. Matt, I hope I can do it here. Yes, so here's the attend data. And I wanted to talk about the attend data a little bit more, and I don't know if the slide is on here, but it's really about the different benefits in the subgroups. And there was some very interesting data specifically based on race. Anyone want to volunteer and tell us a little bit more about that? I'll see if I can find the slide. I don't know if it's in here.
Here comes it, blue zones.
Is it next one, blue zones? Here we go. Oh no, that's the other thing.
Yeah,
So,
you can probably skip ahead from this. This is basically a lung cancer trial that showed, equivalence of the PD-L1, or, not a big difference, but kind of reassurance that the PD-L1, the PD-1 inhibitors are performing fairly similarly. Next slide.
Oh, really? Hang on, Matt. I saw this a little bit different, but I want to talk about the different subgroups in the attend trial.
Oh yeah, this is.
I'll try to find the slide.
This one is a very, very, very provocative trial that Solange presented this year. I mean, head-to-head comparison of two PD-1s and how it goes. Wow.
It's gutsy.
Who dares to do
this
that?
is how I describe this trial. It's gutsy. People don't do this. So I'm letting you guys derail me, but that's okay. People do not do comparisons of Me Too drugs. This is incredibly brave. And it actually, I mean, I know the studies it's not statistically significant, but it does show a trend in favor of dostarlimab, but it's very short follow-up time, right? About 21 months. So we'll have to wait and see. But I just applaud the investigators for having the courage to do this type of study. And as you mentioned, this is non-cell lung cancer. But how can this translate to the other disease types?
But this was not sponsored by any of the pharma. That is the thing. Pharma will never do such trials. So these are the trials we have to do ourselves.
All right. Great. So guys, don't look at the slides. Just tell me about the populations in the attend trial and what you thought about that.
Well, I think, the two recent trials coming out, attend and DOE, both had a large Asian component of patients from Asia. And, the concerning thing there is across all of our studies that there does look to be differences based on geographic region. Understanding those differences initially, I thought, well, COVID had a big impact on Ruby, where there was a little bit of a delay. So I thought perhaps that some of those differences seen European versus US was due to just follow-up time. And now we're kind of seeing these same trends in DOE and in attend, where the Asian patients don't seem to be benefiting. And in fact, some of them, you could even imply there could be harm to checkpoint in an Asian patient, or patient treated in Asia, I should say. And I'm just kind of at a loss, but is my lovely partner here, Dr. Mansoor Mirza, just told me, let's wait on all the molecular data before we jump to any conclusions, because there's such a complex story we have ahead of us. But I don't want to ignore something either, but I think really the great thing is having these worldwide trials